Good morning, and thank you for joining today's Learning Series webinar. All participants are muted. If you have a question, please use the chat feature. Your questions and comments in the chat will only be seen by the panelists. We will address all questions at the end of the presentation. Please note, information about continuing education credit will be shared at the end of the webinar. A recording of this webinar and PowerPoint presentation will be made available later today on knockoutday.drugfreenj.org. This website also has a full schedule of upcoming 2023 Learning Series webinars. To get us started, I would like to introduce the Partnership for a Drug-Free New Jersey's Director of Opioid Response and Prevention Outreach, Angela Conover. Angela.
Thanks, Greg, and good morning, everyone. I thank you for joining us for this Learning Series webinar, The Collateral Impact of Opioid Misuse. I just want to let you know that today's webinar has been approved for 1 AMA and ANCC credit and 1 ACPE contact hour. The American Academy of CME Inc. has been authorized by the American Academy of PAs, AAPA, to award AAPA Category 1 CME. American Academy of CME Inc. is an American Dental Association, CERP, recognized provider. And any pharmacists who are claiming credit, your information will be uploaded to CPE Monitor within 30 days. And we have no disclosures of faculty or planners for this learning activity. Today's webinar is brought to you by the Partnership for a Drug-Free New Jersey and is being held in collaboration with NJ Cares and the New Jersey Office of the Attorney General and the Opioid Education Foundation of America. And I thank them for their partnership, support, and collaboration on today's learning activity and throughout this year-long learning series. And I'm so pleased to welcome today's expert panelist, Dr. Amisika Nyaku, who is the Assistant Professor at the Division of Infectious Diseases at Rutgers, New Jersey Medical School, Bob Gaidosh, the Manager in New Jersey Division of Highway Traffic Safety, and Adrian Simpkins, who is the Director of Outreach and Capacity Building at New Jersey Coalition to End Domestic Violence. I thank all of our expert panelists for being with us today. I think it's an important conversation, and I know we're going to be discussing the opioid crisis and how it impacts different communities, and we're also going to be touching on alcohol and the impact alcohol has with the opioid crisis. And as it's Alcohol Awareness Month, I think that's really important that we're going to have a bit of that discussion as well today. So without any further ado, Dr. Nyaku, I'm going to turn the presentation over to you.
All right, thank you very much. All right, it's wonderful to see. As you all can see, today is National Take Your Child to Work Day. So there's part of my child. So it's great to see that there are so many people that are attending and are interested in this topic. I know that we have a strict time, so I'll go ahead and get started. And so I will be focusing on the intersections of infectious diseases and the opioid crisis. So next slide, please. So I don't have any relevant financial disclosures. Next slide. And let's go ahead and jump directly into this. What is the impact of the opioid crisis on infectious diseases? Since I'm an infectious disease provider now, because of the pandemic, many people understand much more about what kind of work I do. And I think that it is important for us to understand that not only are we directly taking care of infectious diseases, but there are many different intersections as well with other conditions. And so we'll talk about the opioid crisis. Next slide, please. So I think one of the things that underscores the data that I'm going to show you is that for all types of infectious diseases, we've had significant increases that correlate or are directly attributable to the opioid crisis. So the figure on the left comes from a paper that was looking at changes in the diagnosis of infective endocarditis. And so that is bacterial infection of the heart valves. for these bacterial infections of the heart valves, if you might actually think that there's only one line on that graph, but there's actually two. There's a dark green bar that looks essentially flat over the time. And what that is representing is the incidence of infective endocarditis diagnoses in individuals between the ages of 18 to 29. Those that have that dark line do not have an opioid use disorder diagnosis. And then those that are the hash purplish line are individuals in that age range with an opioid use disorder. And so what we see is a tremendous increase, especially in younger individuals that have an opioid use disorder, to come in with a diagnosis of endocarditis. Similarly, when you look at the graph on your right, this is showing changes in healthcare utilization. So emergency room visits, hospitalizations that are related to opioid use disorder. So this does not show the absolute number, but it's showing the relative increases. So in 2002, which was the baseline time, everybody's at 1, because we're just going to say the baseline is 1. And then in 2012, we see the relative increases. So all opioid use disorder related diagnosis increased by roughly 1.7 times. For endocarditis and opioid use disorder, it was almost 1.105. For opioid use disorder and osteomyelitis, right, serious bone infections, it more than doubled. And you see for septic arthritis and epidural abscess, again, these things more than doubled. And so significant increases over time for these types of infections. And all of these carry significant morbidity and potential mortality. And so for the next slide, we'll take a look at some of that mortality data. So here, this really hones back into about infective endocarditis. I think it's important for us to understand, to be able to appreciate the magnitude of the mortality, is to also understand about the demographics. For somebody that has an opioid-related infective endocarditis diagnosis, their average age is 37.6 years. The breakdown between male and female is 53.7 to 46.3, so almost half and half, as compared to non-opioid related infective endocarditis, where the average age is 60.9. So those individuals are significantly older. And then that skews towards, in terms of the sex breakdown, that skews more to being more common in men with 58.8% and in females, 40.2%. So now if we shift and we look at our mortality, we see that the mortality for someone with infective endocarditis had, we'll say, roughly hovered between 6 and 10% up until we got to around 2011. And then it has precipitously increased to almost 20%. And any death is, part of the work that we do as healthcare providers and as a society is to prevent premature mortality, make sure that people have quality of life. But I think one of the things that we really have to take a step back and appreciate is that we're talking about 20% of individuals, almost 20% of individuals that are relatively young, right? Less than their 40s, potentially, are at risk of dying as a result of this infection, because of these changes that we're seeing. And it really has many kind of consequences and calls to action for us to do things differently in terms of our systems of care, which I'll talk a little bit about at the end. So next slide. So another place where we are concerned about the rising infectious disease impact is related to communicable diseases, or diseases that can be transmitted from person to person. And so here now we'll talk more about our viral infections. And so first we'll start with hepatitis C. So we see that, again, when we look at the data and the trends, that acute hepatitis C infections have increased from 2009 to 2018. And so you can look and you can see the breakdown for the different age groups. And essentially, or what ends up being the most striking is that for those individuals that are 0 to 19, 20 to 29, or 30, 39, especially, we're seeing we're seeing significant rises. And when we look at this, one of the biggest things is that because we know that the majority of people who get acute hepatitis C will develop chronic hepatitis C and therefore will require treatment, keeping an eye on these early trends ultimately has impacts on what we're seeing in terms of long-term trends and future transmission. And so if we go to the next slide, we look at what now is the distribution of individuals living in the United States that have chronic hepatitis C. And so the diagram, the kind of pie chart that's at the bottom on the left shows the breakdown based on the different generations. There was a big, previous campaigns were focused for hepatitis C elimination on addressing people born between 1945 and 1965. So the boomer cohort, but actually they represent just a little more than a third of individuals that have chronic hepatitis C in the US as of 2018. And that really almost 2/3 of chronic hepatitis C are in millennials and Generation X. And so again, this figure that kind of shows this distribution of the cases shows that there's a clear bimodal distribution where that earlier cohort, the 1945 to 1965, we see there's a peak there, but then we also see a peak in people that are roughly between the ages of 16 and 40. And then you can also see that there's a higher prevalence in male population across all of those age groups as compared to females. So next slide. So a lot of my work is focused on HIV. And again, this story that we're having more infections because of the opioid use crisis also applies to HIV. And so this just shows all of the different places where there have been HIV outbreaks in persons who inject drugs. And so we see these are from various news articles. And then if you click on the next slide,
Look what he did.
if you click on the next slide, or sorry, you can hold it there, thank you. And so for this was projections from the CDC that based on trajectories and looking at epidemiologic data, not only did you have vulnerable counties, but you also had states that were vulnerable to HIV or HIV and hepatitis C outbreaks. And so we see that this means that much of the country is impacted potentially. And so now what I want to do is I want us to move into how do we address this? What are the interventions? So next slide. All right, and next slide, thank you. So really harm reduction is where we should be focusing our energy. And so let's define this. So this is policies, programs, and practices that aim to minimize the negative health, social, and legal impacts associated with drug use, drug policies, and drug laws. Harm reduction is grounded in justice and human rights, and it focuses on positive change and working with people without judgment, coercion, discrimination, or requiring that they stop using drugs as a precondition of support. And this is one of many definitions, because at the end of the day, harm reduction is really tailored to the community. So why don't we move to the next slide? Because across all of these definitions, there are core principles, and that's respect for human rights, effective policies, as well as effective services. And so we'll go to the next slide. And I want to show you that these are effective and evidence-informed services. So syringe access, safe syringe disposal, safer drug use, naloxone, medication-assisted treatment or MOUD, supervised consumption sites, drop-in centers, housing first, pharmacy access, referral and linkages to care. All of these things have data behind them that support their efficacy in improving outcomes for people who use drugs. And so if we go to the next slide, this is just a high-level summary, just given our time, but these interventions decrease overdoses, HIV infections, hepatitis C infections. They also increase quality of life, entry and retention in treatment, chronic disease management. So if somebody is living with HIV, for instance, it improves HIV outcomes, as well as they've demonstrated that they're cost effective. And so this is, there's been much attention, much more widespread attention to harm reduction principles because of the White House's drug control strategy, which we're all very happy about, that was released in 2022. And so now we're all looking forward and very hopeful to see what implementation and scale up looks like. And so in summary, if we can go to the next slide. In addition to the rising numbers of opioid-related overdose deaths that we are all very sensitized to and aware of, the opioid crisis has resulted in significant increases in all infectious diseases. And so therefore, more widespread implementation of harm reduction services will be the most effective public health approach to curb this trajectory. And there is strong data to support that approach. And with that, I thank you all for joining, for sitting in, and I turn it over to back to Angela.
Thank you, Doctor. That was significant information, and looking forward. I know we have a lot of questions on that. We'll hold all the questions until the end of the presentations. I am now going to turn the presentation over to Bob Gadosh, the manager of New Jersey Division of Highway Traffic Safety. Welcome, Bob.
Yeah, good morning, everybody. Thank you very much for having me on today. I do appreciate the invitation. I'll apologize right up front for my voice quality. I've been a bit under the weather this week. It's affected my voice more than anything else, but we'll plow forward here. And I enjoyed the last presentation. I wish I had some of my children here to wave on camera, but they're all grown and out of the house. That would probably look kind of silly to have them on here waving. But again, thank you for inviting me to be here today. This is a very important topic and an awesome turnout that I see from the number of participants. I'm involved with a lot of webinars in the traffic safety realm, and we usually don't get turnouts like this for our webinars. This is great and speaks to how important of an issue this is. And personally, I've lost 2 close family members myself to opioid addiction over the last number of years. So it hits very close to home for me also. So I definitely glad to be here and weigh in a little bit on our perspective on all of this. So next slide. Again, I'm with the Division of Highway Traffic Safety. I'm the manager / deputy director of the division. We're a division within the Attorney General's Office, Department of Law and Public Safety. We're the lead agency for the traffic safety program in the state of New Jersey. We're primarily federally funded by NHTSA, National Highway Traffic Safety Administration. We receive a block of funding each year from NHTSA to do the traffic safety program for the state of New Jersey. Each year, we develop a highway safety plan based on data to set up goals and objectives and programmatic things that we are going to look to do to carry out. To ultimately make the roads safer in New Jersey. That's really what we're all about. We're primarily a grant funding agency. The main part of what we do is we get this federal money and we grant it out to agencies that are going to assist and help, hopefully, making the roads safer in New Jersey. So as you can see here, our mission ultimately is the safe passage of all roadway users in New Jersey as we move toward 0 fatalities. And we promote statewide traffic safety programs, primarily in the education, engineering, and enforcement realms. And again, we administer and coordinate grant funding for state and local traffic safety projects. Now, traffic safety is a huge, serious issue in New Jersey, and one, as I say all the time, affects all of us, right? We're all road users, our families are all road users, so it's definitely a critical, important issue for us every day in terms of safety and quality of life. Last year, 2022, we had 694 people killed on the roads of New Jersey, which is certainly a tragic number, especially when you consider our belief that all of these crashes and fatalities are preventable. There are reasons behind them in ways that they could have been prevented. So everything that we do in our division and in our efforts are to try to reduce that number and make the environment safer for all of us. So next slide. In terms of the areas that we work in, as we identify what's going on the roads of New Jersey, several key things come to the forefront, and these are some of our real priority program areas. We're in the occupant protection realm, of course, which is promoting seatbelt use and proper child safety seat use. We do a lot with the other vulnerable road users, pedestrians, bicyclists, motorcyclists. We've got a huge pedestrian safety issue in New Jersey. That's an issue for another day, but just putting it out there. Speeding, distracted driving, we all see that. Major issues causing crashes on our roads. So we do a lot to address that. And last, and certainly not least, the impaired driving issue, which we are here to talk about today. So next slide. Statistically, when we talk about impaired driving, we're talking about driving, folks being impaired by alcohol, illegal drugs, or prescription medications. And the statistics are very sobering, no pun intended. About a third of all traffic fatalities in the US involve a drunk driver. That equates to about one person killed every 45 minutes, in this country in a impaired driving related crash. And alcohol gets most of the attention, but there are many different substances that can impair your driving, including, over-the-counter and prescription drugs, as well as illegal drugs. And we're in a very complex environment now in New Jersey in terms of impaired driving. Certainly we have the long-standing issue of alcohol being an impairing substance. We've known about that for many years. The environment there has changed over the years, of course. What was socially acceptable 20 years ago is not so much now, but we still have a stubborn issue with alcohol and impaired driving. Throw that into the mix these days that we have legalized marijuana now on the books. That's a concern, something we're tracking in the traffic safety field, as well as the prevalence of illegal drugs and opioids as well. Huge issue, which again just adds to the complexity and really a multi-layered challenge in terms of impaired driving in New Jersey that we're dealing with. So on to the next slide. Specifically here in New Jersey, some of our data over the last 5-year period, over 33,000 alcohol-involved crashes in New Jersey, 662 fatalities. That's 23% of all of our fatalities in New Jersey were alcohol involved. And the percentage of drug-related fatalities actually a little bit higher during that same period, 754 drug-involved fatalities in New Jersey. That's 26% of all the total fatalities in the state were involving a drug-impaired driver. So impaired driving definitely a major issue contributing to our motor vehicle fatalities in New Jersey. So next slide, please. In terms of the consequences, I mean, at the bare minimum, when a person is arrested and convicted for impaired driving, there's big costs involved, probably a minimum $10,000 cost in legal fees, court fees, motor vehicle surcharges, and then getting your insurance increased, your car insurance, or kicked out by your insurance company. There's a lot of monetary costs involved with impaired driving. Of course, losing your license, the implications for work and family, all those kind of things. It's a very significant cost financially when you are arrested and convicted of impaired driving. Next slide. But again, that's minimal compared to what the real damaging costs can be. It goes way beyond possibly losing your license. We've had some very horrific recent crashes in New Jersey directly attributed to opioid abuse. It's out there. It's definitely an issue. In fact, one of the things we're hearing of late from our law enforcement partners, of whom we all work very closely with, is that we're hearing that a lot of people with opioid issues, they're going to wherever it is to buy their drugs, and I guess whatever in the rush to get their fix, they're using the drugs right there in their car where they purchase it, and then not wanting to stay there, they're driving off to wherever, going home, and obviously that's a recipe for disaster there. We're seeing that a lot at the local level, people driving severely impaired by opioids, and that can result in some very serious issues occurring. So next slide. There's been also a number of studies done on opioid impaired driving. It definitely points to this as an ongoing and emerging issue. General recommendation is certainly for awareness, on the part of clinicians, therapists, to really counsel patients on the risk of impairment when they're initiating therapy or prescribing opioids, or recognizing a person who may have, opioid issues, again, pointing out the necessity for better education with opioid impaired driving. Now, I know easier said than done, but this is a great opportunity, I think, for us, for the first time, in the traffic safety realm, to really try to work with the clinicians, therapists, folks like that, to get this important information out, because it is such a critical issue. Really, we need your help. For sure, we need your help. So next slide. Couple things that we're doing just generally. A lot of our work, again, relates to the enforcement and the educational side of things. On the enforcement side, we put a lot of grant funding out every year to police departments for impaired driving enforcement. We fund police departments for year-round enforcement activities. They do patrols, they do the fixed checkpoints for impaired drivers. We do a couple of major enforcement crackdowns each year. You've probably heard of the Drive Sober or Get Pulled Over campaign. That's run twice a year. That's a major national NHTSA program that we support in New Jersey. There's 2 crackdowns, one at Labor Day, one in December, where we've got a flood of police out on the roads looking for impaired driving. We're also very much into the training side of things. We do a lot of police training for the ALCO test operation. That's the breathalyzer machine that suspected impaired drivers blow into when they're taken back to the police department upon arrest. We train all the operators in that device. A couple of other programs, SFST and ARIDE. SFST is the standardized field sobriety testing, that if a person is pulled over suspected of impaired driving, they go through that roadside test, walk the straight line, do those kind of things that the police will do on roadside. That's SFST. We're involved with that. And ARIDE is advanced roadside impaired driving education. That takes it one step further, teaches police some of the issues involved with detecting drug impaired drivers. So we're involved in that also. And lastly, drug recognition experts is a huge program that we're operating now. We have several hundred of these trained DREs in the state. These are trained police officers who, upon the suspected arrest of an individual for impaired driving, they can run a battery of medical type tests to determine if a motorist is impaired by drugs rather than alcohol. So the DREs are out there doing very important work in this type of area as well. So next slide. We do a lot of educational things too. As I said, we've been always working to try to raise awareness about this issue. Recent thing we did, we put together a brochure on the dangers of cannabis and driving. We did that in partnership with AAA and the New Jersey Cannabis Regulatory Commission. This brochure is going out with all cannabis sales in the dispensaries. So we're happy to have that out there, some good information. We do a ton of social media on an ongoing basis, all relating to impaired driving. That's an ongoing thing. We try to get the message out about this important stuff. Next slide. And we do major paid media campaigns also. We've done a couple of late. Some of you may have seen this one, our Wheel Risks campaign, early 2022. This was out there in billboards, social media, all over the place, YouTube, Google, to get some of the messaging out about the different things that can impair you while driving. We got good response and good reactions to this campaign. And one other one, next slide, a little more recently, we did this campaign last December, kind of tried to put a human face on the issue. Again, we had billboards, posters, turnpike rest stops, all kinds of information going out on this. We did some radio as well. This was just another impaired driving campaign that we did. Again, just media outreach. It's something that's always a part of our plans, and we're always looking for new ideas and new ways to get this message out. So, next slide. Kind of in conclusion, right now we're in the process of putting our plan together for the next 3 years. To NHTSA that we submit to then get funded for our programs. One of the new things that we're trying to do is, where I think you guys can all assist with this, is we're going to try to be a little more holistic in our messaging to get some referral information out. When we're talking about impaired driving, our programs, we're going to start to work in some referral information in there too, to hopefully reach some individuals that may have substance abuse issues, before, they get behind the wheel and potentially get into a crash. So that's something that we're regionally in our tri-state area working on. So stay tuned on that. And certainly we're looking for good ways that we can get that information out there. So that's basically it. Again, thank you so much for allowing me to be here with you today. And we're looking for an ongoing partnership, anything we can do, any ideas that you folks have for us to help spread this important message. We are very interested in hearing and working with you on. So thank you.
Thanks, Bob, and thanks for that great snapshot of what we're really seeing in New Jersey and that impact on our roads. I know many of us who are, I'm sure, on today are on those roads a long time and a lot of time each day. So sobering information, but important to have. So thanks for being with us. And we have some questions I know for you, but we're going to hold those until the end. Next, I'm going to welcome Adrienne Simpkins. Adrienne, welcome.
Thank you all so much. It's great to be with you all this morning, early afternoon. I'm Adrienne Simpkins from the New Jersey Coalition to End Domestic Violence. And I'm just going to explain a little bit about who we are. The New Jersey Coalition to End Domestic Violence, or NJCEDV. We are a statewide leader in collaborative community and systemic responses to domestic violence by providing public awareness training, advocacy, policy development, technical assistance, and other supportive services. We envision a world where all are free from oppression, injustice, and violence. So I know I have about 10 to 12 minutes to share a lot of information. So I'm hoping that this can just be the beginning of an ongoing dialogue and a connection for all of us to better understand the experience of those that are experiencing intimate partner violence, also those who are perpetuating that harm as well. Next slide, please. So I'm thinking many of you have probably seen this, but this is how I want to frame our conversation today, by highlighting power and control as sort of like the catalyst or the driving force behind intimate partner violence. Intimate partner violence is rooted in power and control. And this power and control wheel is a tool that we use not just to understand some of the dynamics and tactics used in intimate partner violence, but also to help those experiencing it to understand what it is, or give language to, because they certainly understand what's happening, but sometimes may not have the language or the understanding of long-term impact. So using that tool as a guide to explain what intimate partner violence can look like. And we know that it's certainly more than the physical aspects of violence, but that it can also be mental, emotional, economic, sexual, and so on. And so when we're talking about substance use, particularly for our audience today, opioid use, we frame it from the term substance use coercion. I became familiar with the term from some of the resources that are provided by the National Center on Domestic Violence, Trauma, and Mental Health. They're an awesome resource that we use when we are training our programs. They've done some regional trainings for us as well. And so they help us to, again, give language to and to explain these abusive tactics that are used towards a partner that may be using substances, and how it contributes to a broader pattern, of abuse and control. And so in some of the data, I will admit that it is limited, and it's an area that can be, further research can be done in, but it does show that survivors were often introduced to opioid use by their intimate partners. So perhaps using together, their partner could be selling drugs. Also, the use began as pain related to physical acts of domestic violence or other chronic conditions that can be developed because of prior trauma and violence that they've experienced across their lifetime. The data also shows that folks have tried to get help but partners can interfere in that process. And I'll explain a little bit more about that on the next few slides. And then lastly, like the fear of reaching out to help because they're afraid that they would be believed, or the potential for arrest or other systems involvement. Next slide, please. So we know that opioid use, substance use has a link to trauma. So the folks that we see oftentimes have traumatic experience that predate them coming in for our services. We know that the risk for violence is greater when folks are using, but again, if there's a history that already exists, that there can also be linkages to other mental health challenges like PTSD, anxiety, depression, which can contribute to the increase of use. And this is the case for many survivors. Also, when we're thinking about folks with marginalized identities, so particularly the statistics show that women are impacted at disproportionate rates, as well as transgender folks who have a history of violence and abuse and trauma. We have the ability to kind of understand the context of their experience before trying to help them. And so in my experience, I've had the opportunity to lead support groups, do individual counseling, and also work in treatment facilities, and find that folks do share childhood histories of abuse, childhood sexual abuse, exposure to domestic violence, or often experiences those types of violence and abuses throughout their lifetime. And so this slide in particular is focusing on some of the barriers to seeking help that folks can encounter. So a partner that sabotages their recovery efforts or their desire to reduce use. The pressure can certainly come from a partner if they're leaving drug paraphernalia around the home, if there's limited access to the support needed to actually attend treatment. So maybe, if someone's partner agrees to watch the kids while, they're supposed to go to services, maybe keeping them from having access to childcare or not providing childcare or transportation, et cetera. Creates isolation from supports like family and community support. So again, there may be other programs they're involved in, other folks that they're connected to. And so isolating them to prevent them from getting the support that they need to follow through in their recovery efforts. I do want to highlight making threats that cause reluctance to reach out for assistance. So because of the criminalization of mental health and substance use, if someone were to reach out for help, it could result in, again, other systems being utilized like DCP&P, which could result in the removal of children from the home, as well as arrests. And we know that there are disproportionate impacts in terms of legal system involvement for folks of color. So there are a lot of risks and a lot of factors involved as it relates to the barriers that survivors are facing when, seeking support. And I had more talking points, but in the interest of time, just want to encourage you all also to reach out if you wish to consider or to have more dialogue about this particular topic. And also some of the barriers come from our system. So the policies and procedures that are in existence, the stigma that exists around intimate partner violence and substance use, and how our personal biases and beliefs can affect the treatment of folks. Requiring that, you only do one service at a time. So what we see in shelter programs is oftentimes when folks are screened and they disclose a history of substance use, it's absolutely possible that they are encouraged to seek treatment first before coming into shelter. And really, we should be offering safe housing first, and then connecting with other partners to ensure that the supports that they need are available to them while they're seeking safety, because safety is paramount and is first and foremost in the line of work that all of us do, but that we do specifically as domestic violence program providers. Next slide, please. So I just wanted to highlight some contributing factors, and I do want to just say that in our work, being careful not to victim blame, shame, or guilt survivors who are using opioids or experiencing domestic violence. The responsibility for violence is on the person causing harm, and not on the person that is experiencing that harm and that violence. Opioid use does not cause intimate partner violence. Of course, it heightens the risk for violence, but often the power and control dynamics are still present and used even when substances aren't involved. And so this slide is, again, just highlighting, some things that do contribute, but again, are not causal. And so that, it's the effect of the substance that can impact mood, how the substance impacts perception and can distort one's perception, impacts people's impulses and behaviors. And again, the conflict and stress that it creates as a result of in relationship dynamics as a result of substance use. And so moving on to the next slide, please. Considerations for us as service providers, I just want to highlight two things: collaboration and training. So ensuring that staff in programs, medical staff, all folks that have, and we all have connection to folks who are experiencing intimate partner violence, is ensuring that staff are following and potentially doing thorough cross-training. So, we're sharing information across disciplines with one another, understanding the intersection of substance use, intimate partner violence, mental health, and trauma, the prevalence, dynamics, and impacts of substance use coercion, harm reduction strategies that meet folks where they are, addressing the stigmas that exist, and also making services accessible to all. So addressing some of the inequity that we see on our work through language access services to offer interpretation and materials for those who may not speak English as a first language, avoiding implementing unnecessary program rules, which is the layered conversation as well. Evaluating the strategies that we use, ensuring that it is culturally responsive, trauma-informed, and meets the survivor where they are. And then lastly, for medication-assisted treatment, offering options for that, as well as wraparound care, and offering a full array of treatment options. And just all of us remembering that there's not a one-size-fits-all approach to our service provision and care. So next slide has my references that will go on the website. And then if you go to the slide after that, you can contact us for more training, and let's keep the conversation going. Thank you all for your time.
Thanks, Adrienne. Thanks for that that presentation that had so much information on in different ways that perhaps we can explore and continue that conversation on how we can get involved in addressing those barriers. I know we have, so thank you for your presentation. I know we have time for questions today, so I'm really excited to get to some of your questions. If you have anything and you want to add to the chat, go ahead and do that now. But Doctor, I'm going to start with you for the first question, because you talked about harm reduction methods and the evidence behind harm reduction methods. And so we had a question about what type of harm reduction methods would you recommend to families who are impacted? And also, what would you recommend to someone who is working in the prison setting?
So there's a couple of different things when we think about harm reduction. One is to understand that, there's a policy component, right? There's another that focuses on what is the kind of social movement and climate that we exist in. And then there's, this intervention that are harm reduction. And so I think that, and the reason why I'm breaking it down this way is because I think that the systems that we work in, right? So the society that we live in, or the place places where we work, we need to think about what are the policies, right? What are the regulations? What is the cultural expectation around what we can and cannot do in our workplaces or in our homes or in our communities, and to advocate for change and to adopt that harm reduction model. So in some of that, it comes out in the national drug control strategy focused on that. Now, in terms of the question that I think is also wants to hear about, what are specific interventions? So everyone having access to naloxone. So be it you in the community, in everybody's workplace that they have it, especially in our prisons and jails. And to go forward deeper about in the prisons and jails, it's not only about the medical staff and the correctional officers having it, but also there needs to be a greater push for there to be the people that are there themselves to have that on them and have that accessible, so that if they witness another person having an overdose, they are able to intervene. So that is, I think, or one of the many interventions that are necessary and should be ubiquitously applied across all of the different kind of places in which we exist. In terms of going back to this question about in corrections, so the harm reduction has been endorsed by the World Health Organization, the United Nations Office of Drug Control, UNAIDS, as a strategy that should be employed in all of our jails and prisons. And this is speaking on a global level. And those kind of key components are around overdose prevention, opioid use disorder and other substance use disorder treatment, HIV testing and prevention, as well as HIV treatment, hepatitis C testing, hepatitis C treatments, and then around recovery support, which includes having peers that are engaged in that and people having multiple different options in terms of what kind of mental health and social support that they receive. So I hope that that touches on broadly what are some of the different harm reduction approaches and strategies to answer that question.
Thanks. I think it does. Obviously, if anybody has additional questions on it, we can always get some additional questions to the doctor after this event, if there's a specific question or community that you're working with. I did want to mention before we go to the next question that we launched the poll. It should be on your screen now. And this poll is just for review purposes for today's event. And we appreciate your feedback and information on how to obtain credit is on the screen now, as well on the slide and also in the chat. So I know we're getting a lot of questions on how to access your credit. So I just wanted to go ahead and mention that as well. I'm going to go to the next question to Bob. Bob, we had some questions on our aging population, and we know that perhaps maybe our aging population is being prescribed opioids more than others. And can you talk to us about impaired driving with that population and what can be done for those of us who are on today?
Yeah, that's the aging population in general can be a challenging topic in the traffic safety realm. I don't know that we have seen any kind of a recent increase in opioid related or impaired driving crashes in that area, but the older driver population is always a challenging one, and a lot of it comes down to making the decision as to what is the right time for an individual to stop driving, and that's always a difficult decision for any family to take. So I don't think we've seen it on the impaired driving side, but there are a number of different resources out there. We have a new older driver resource center that was recently launched that is available through Voorhees, Rutgers University. It's a great resource with a lot of different information on that website about all the different issues facing older drivers and tools to help older drivers transition to some other means of transportation. So again, thankfully, nothing particularly recognized on the impaired side, but again, the issue with the older drivers is always a challenging one, and one that often comes down to just, personal decisions and families to kind of have to make that right decision when the time comes.
Thanks. And Doctor, I'm just going to throw it back to you for any programs around opioid use disorder toward that population that you're aware of. I know it's not necessarily your specialty, but if you could speak to harm reduction on that population as well.
I saw that question, and it's a good question because that's definitely something that is important given the unique needs. As a field, we always, value our geriatricians. And unfortunately, off the top of my head, I don't have a specific, but I will look into it and send it out to you all to share with the group.
I appreciate that. And it is true. It is a topic that continues to come up also from, I know, many of our repeat attendees who ask us to really look at that aging and senior population in our state. So appreciate any additional information you can provide. Adrian, you talked about being aware of trauma-informed approaches. Can you talk more about that? There's some confusion from our attendees on exactly what that means and what that means to someone who may be in the prevention, treatment, or recovery field, or may even be a family member and looking for correct services.
Sure. So I think, there's many definitions to trauma, and what that is and what that could look like. But what it really is a agency-wide commitment to ensuring that people feel safe in the environments that they're in. So we're taking into context the fullness of their experience, looking at the whole person and, what they're bringing with them, before we're trying to treat them. So just gaining an understanding. And so what that can look like, again, the way that it's been explained is that the whole organization is trained, from the person at the front desk to the CEO of the organization, and understanding that we all have experienced trauma, and just taking into consideration our personal experiences, the physical environment, the sensory environment. So like, what colors do you use? What does the material look like? Will people see themselves reflected in that? Because those are things that contribute to establishing that safety and that trust that is needed, again, before offering treatment and trying to address the problem, if you will. Also, looking at our intake and our assessment processes, are we asking the right questions? Are we asking questions that are important? And are we re-traumatizing folks? So are we asking questions that's going to activate their trauma response, or their, cause them to have that fight, flight, fawn, freeze type of response? So I think it's about how we're working with folks more so than necessarily what we're doing. And there's information on the National Center from Domestic Violence, Trauma, and Mental Health that you can refer to. They have agency assessments that you can do, and there's more questions that can be asked. But I did want to share the key ingredients for a trauma-informed approach, and this is from SAMHSA. And so it's patient empowerment. So, building on people's strengths, giving them choices, or letting them know what choices they have, collaboration, which I talked about at the end of my presentation. And as I've also mentioned in this discussion, safety and trustworthiness. And so building that with folks, again, before treating the substance use.
All right, thanks. I'm going to switch gears for a minute. Doctor, I'm going to just go back to you. You talked about infections, and the question could be, could the increase in infections be tied to opioids' effect on the immune system? So is that something that...
Yes, definitely. I mean, it is definitely not the primary driver. So when we think about what it is that drives any infections, there's the biologic component, there's also a behavioral component. So what puts people at risk, because not everybody is at risk for all infections. And again, when we're even thinking about this in the context of opioid use, not everybody that uses opioids or has an opioid use disorder is going to be at risk for infections, or all the same infections. And then there's also understanding about kind of our social and structural context. And so in terms of the biologic context, we do know that opioids are immunosuppressing, and so that will make people more vulnerable. And then we also know that injection drug use, that when we have looked at models and there have been these kind of basic science studies, that there's something about injection drug use or injecting that behavior that also downregulates the immune system. So there is definitely that biologic component to it, but that is one part of many factors that are associated with it. And at the end of the day, the biggest thing is more people are using opioids, more people are injecting opioids. And so that really is the biggest driver for why we're seeing this rise in these infections.
All right, thank you. We're coming to the end of our time, so I'm just going to go to all of you with one last comment to leave us on for the day. Before I do that, Dr. Nyako, I just want to mention that everyone is sending their hellos and greetings to your daughter. We saw her and heard her, and so glad that able to be with you today, and thank you for joining us and for having her there. So we all send our hellos to her as well. But Adrian, you know what? I'll start with you. I mean, I know you talked about a lot of things that maybe you didn't have time to address today. So for all of us who are on, again, from various fields, but even as our roles as friends and family members, what is it that we can do? What is one last point you want to leave us with?
Sure. So one of the things that we stress in our work, and this is, for working with folks experiencing intimate partner violence or using substances, is to meet folks where they are, and also understand that the choice ultimately is theirs. And so sometimes, we'll get calls from loved ones and family members that, are asking questions or trying to sign folks up for services. And it ultimately has to be the choice of the person who is, experiencing the harm or using the substance. And so the way you can do that is, try as best you can. I know it's hard to see people suffer and go through pain, but just offering them support, knowing what resources are available so that they know what options they have. I think just continuing that support as best that you can, and where you can't, like knowing where to refer to, but also taking care of yourself as professionals and caretakers, because vicarious trauma is very real, and we can experience that. So just ensuring that you have support for yourself, because it can be incredibly difficult doing this work. So thank you all for the incredible work that you do. It's been an honor to be with you today.
Thanks for being with us. And I look forward to continuing this conversation with you and sharing this information. And I also think that your point about taking care of ourselves and giving ourselves that moment or that grace as we're dealing with whatever stresses are in our lives, particularly if we're dealing with someone who's impacted with opioids, is such an important message to keep and to remember and to repeat. So thanks for being with us. Bob, I will go to you next. Any last point to leave with our audience?
Absolutely. Well, again, thank you for allowing me to be here. This was a great presentations and great discussion, and kind of a new audience for us to a certain degree, which is really a great opportunity. Traditionally, as I said, we've worked really heavily in the enforcement area with the police, and also awareness raising. But that only goes so far. Enforcement, of course, is after the violation has occurred or after the crash, unfortunately, has occurred, which you don't even want to get to that point. But that's a lot of what we do. Educationally, we send out the messages. We've been doing that for a long time, but it doesn't reach everybody, and not everybody wants to hear it. I think what all the folks on this call are involved with, the treatment, the therapy, the clinicians, the intervention. That's a huge opportunity to really reach these folks before it gets to the point of, where we have an incident or we have, police or whatever involved. So I think it's a great message to get out today. Certainly, if there's any ideas that anybody has within this network of folks to, formalize and normalize some kind of a program, reach out to me, let us know. We'd love to do more work in this area, because this is a void and certainly a way that we could reach people and help our mission of ultimately making the road safer in a bit of a different way. So thank you again very much.
And thanks for being with us. And your presentation is a little bit different as well for our audience. And so I think it was great, and we appreciate your time in preparing for us and being under the weather and still coming and showing up for us today. So we appreciate that. Thanks, Bob. And Dr. Yaku, I'll leave you with the final comment of the day.
And so thank you, everybody. I appreciate the well wishes to my daughter for coming, and as well as and I think that the thing that I'm most heartened about all of us coming together is, yes, all of our topics are different on the surface, but as we see, there's also all of these shared principles. What I would say is harm reduction is clear throughout everybody's talks in one shape or another, and really that underscores the importance of this. And I would be remiss if I did not give a specific, further emphasis to the need for a continued scale up of our syringe service programs, because that does play a very critical role in being able to eliminate especially these transmissible bloodborne pathogens. And so New Jersey has done a lot of work in removing some of the regulations that have impeded this, but that is a place where we need to continue to advocate and have an eye toward really seeing that as being something that's available across all of our communities, and not impacted by fear of letting these, again, evidence-based and effective programs into our communities. And so with that, I really appreciate, again, being able to participate.
Thanks so much for, again, and to echo what you said, I mean, you're right. There were themes across when we looked at prevention, education, awareness, harm reduction, intervention, helping people access services and recovery. So yes, you all came from very varied backgrounds, but we all know the direction now we need to move forward in to help those that we service or that are in our lives. So thank you again for all of our attendees for joining us, and thank you again for all of our expert panelists. There's information on the screen on how to access your credits if you're looking for them, and we hope that you can join us for our upcoming webinar on May 25th, the rise in polysubstance overdose deaths, and that's going to be presented by HIDA and the Office of National Drug Control Policy. So hope that you can join us for that presentation. Thanks, everyone, and have a wonderful day.